have about 4 medications in your GOPs that are have like a special considerations. Those medications are like cardizem, amiodarone, Lasix. Okay, go to the GOPs, look them up. Okay, don't share in the group. I want everybody to email me by the end of today what those contraindications are from the GOPs. Okay, I want you to start looking at your protocols. Okay, they changed the format of the protocols. It's a little less, in my opinion, it's a little less concise than it was, because now you've thrown all of the BLS in there and you've got your stop points. The older Brendan O'Reilly, I got it. The older medications, the older protocols were a little, in my opinion, a little clearer, because it was just like, do your BLS stuff and trusting that you kind of knew what your BLS stuff was. Now it's throwing it all into one page. Just gets a little verbose. But let's start going through the medications. If you have any questions at any point, please let me know. If you have your homework, hold on.
Just one question before we start.
I'm gonna throw the medications in the group. Go ahead. What's your question?
Can you just repeat one more time what the thing you wanted us to email you tonight was? I apologize.
I'm gonna put it in the group.
Oh, okay, thank you.
I feel like there's bugs crawling all over me right now. It's not a good feeling. Because there is. I can't. Nope. All right, this is gonna be a real fast lecture because I'm being infested by ants. All right. So that's in the group. Drop this down. All right, so medications. Let's start. Got your cardiac meds. So the first medication that we talk about is an ACLS medication. It's called adenosine. So adenosine, the whole point of adenosine is that it's slowing the conduction through your AV node to help interrupt reentrant pathways. I know you have no idea what reentrant pathways are right now, and that's okay, because you haven't done cardiology yet. But basically, you find this medication only in SVT. So anybody who has a stable, narrow, complex SVT. So like if you look down here in the corner, there's really teeny tiny cute QRSs. This is the medication that you're going to give them. Usually it's for rates over 180. There are some considerations of dropping it for a lower threshold. Could everyone just make sure you're muted, please? So a lower threshold of 150 for SVT, just to kind of be a little more aggressive. But again, depends on your area and how your patient's presenting. You actually will also find adenosine in your weapons of mass destruction protocol, because it's used to fight organophosphate poisoning. Okay, working in a different mechanism. But for right now, what we're going to consider adenosine is primarily as a antidysrhythmic. It's going to actually physically stop the heart. You'll have, after you administer it, you'll have a flat line for a few seconds, and the heart will then hopefully restart. Lost my train of thought. Anyway, it's a very short duration. You have to do it as a very fast IV push. So adenosine works best when you have 2 people involved. So if you have a partner, or even if you have a BLS partner who can squeeze a bag, okay, they don't need to do a lot of work. Basically, you crimp off the IV tubing, you push the medication, and then you flush it through really fast, okay? Because it has a very, very short half-life once it gets into the body, okay? So when it's just hanging out in the tubing, it'll hang out for a little bit, but once you give it into the body starts metabolizing it really fast. Some considerations that I like to always give you, especially when we'll talk about this a little bit more in cardiology, is that you really should make sure that you're doing a full assessment of your patient before you're pushing adenosine. Because if you happen to be giving a severely dehydrated elderly patient adenosine for SVT and it's really just a compensatory heart rate, you might have some bigger problems, okay? So while you're doing all of the things that you need to do, which is, doing a 3-lead, potentially doing a GOP is general operating procedures. You should be able to find them in the front of your protocols. While you're doing all of those things, starting an IV, drawing up your meds, you maybe want to give them a 250 bolus and see if it has any impact on their heart rate, okay? And this starts to move into like critical thinking skills, right? Just because a patient has a rapid heart rate doesn't mean that you necessarily have to fix it, okay? That doesn't necessarily mean you're going to be cardioverting them. It doesn't necessarily mean you're going to be giving them adenosine or a cardizem. Look at the whole picture. If you have a patient who has a high fever, has been vomiting for 2 days, and hasn't been able to keep anything down, if you take away the compensatory heart rate, you might put them into some serious hypotension. So make sure that you get a good history, okay? And yeah, you're going to have times when it's just clearly straight up adenosine. Like, you're going to need it. It's an SVT, and that's okay. Your doses for adenosine are 6 milligrams and 12 milligrams. I do believe that they've changed it, that you now need to call for an additional 12. It used to be 6, 12, and 12. I believe it's just 6 and 12 now. So again, check your protocols. Adenosine is one of those kind of medications that you'll use in like bursts. Like the rule of 3, like death happens in 3, happy things happen in 3, adenosine happens in 3. You won't use it for 3 years and all of a sudden you'll give it to like 3 patients. Amiodarone, your next medication. I like to call amiodarone the duct tape of cardiac medications. So it's a potassium channel blocker primarily, but it also has calcium channel blocker properties as well. So it works pretty well for a lot of different things. Primarily in our protocols, we're using it for VFib, VTAC with a pulse, VTAC in cardiac arrest, okay? Wide complex tachycardia of unknown etiology, right? So if you have somebody who's got this funky looking tachycardia, and you're like, I'm not 100% sure it's VTAC. It looks like it has P waves, and again, we'll talk about that in cardiology. You can still give amiodarone. It's fantastic. Amiodarone is very effective. It is highly, highly renotoxic and liver hepatotoxic. Okay, so patients who have liver or kidney issues, you might want to call to get discretionary orders about this medication. Okay, and by like liver or kidney issues, I mean like they're on dialysis, they're yellow from cirrhosis, right? They have like a significant history. If you're sitting there and they're in VFib or they're in VTAC and you're like, I don't know, they're a little on the jaundiced side, you might want to give it to them regardless. We use amiodarone in 2 different ways. So if you're dead, it's a 300 milligram bolus. Amiodarone burns. Dead people generally don't complain, so 300 milligrams of amiodarone IV bolus for your cardiac arrest patients. On the other hand, you're going to give it for live patients as a 150 milligram IV drip over 10 to 20 minutes. Usually you mix it in a 50 or 100 bag, usually 100 bag because 50 bags don't commonly exist on the ambulance. It's usually 100 bags. Most of the time, it's preferred that the amiodarone is mixed with D5W. However, normal saline is also completely acceptable. What you have to be careful with when it comes to amiodarone, hold on, I think I have a saline bag laid around. I don't. I have this giant thing of Purell. When you're mixing it, and you're going to learn this hopefully in lab also, so you put your medication in. Amiodarone gets really sudsy. Sorry, killing bugs again. Amiodarone gets really sudsy, so when you're mixing it, you just want to do a gentle like rock it back and forth. You don't want to go like this, because then you'll end up with like all these suds, because that's just what amiodarone does. This is Purell, not amiodarone. I don't advise giving this much amiodarone. So you have to just gently kind of rock it back and forth to mix it when you are at that point that you're administering a drip. It takes a very long time for amiodarone to clear the system because it just lives in the fatty tissues. So you can have a patient who's on amiodarone for an extended period of time who might still be experiencing some effects. So you might not get the same response from it that you expect. So just something to keep in mind. Hard and fast contraindications, hypersensitivity to iodine, okay, because it's a main part of the medication, and cardiogenic shock. If you have a patient whose heart is not pumping effectively, you don't want to then take that pumping effect away, okay, right? Amio in the pre-hospital state. Yes, it is. Yes, amiodarone toxicity can be an issue in the pre-hospital setting. Mostly if patients are like overdosing on it, they'll kind of present like almost like beta blocker overdoses, because they will prescribe patients at home amiodarone, especially patients with liver and kidney failure. They can develop a toxicity. They might be, hypotensive, bradycardic, kind of what you would expect from like a beta blocker or other cardiac medication. Other issues that you might see is patients who are on amiodarone and warfarin. Those two don't play nicely together. Usually those are two medications they try not to mix on the pharmacy side. Aspirin. All right. Aspirin is our #1 antiplatelet aggregator. We use this for chest pain. Aspirin's pretty cool. Derived from willow bark. Very natural kind of medication, highly acidic. So when you take it, acids like acids, which means that when it goes into your very acidic stomach, it's absorbed very quickly. It binds to thromboxane 8 or to the platelet to prevent the formation of thromboxane A2, which is part of your clotting cascade. Okay, it's what kind of makes platelets sticky. It permanently binds to platelets, and that means that those platelets are going to be ineffective at being platelets until they're repopulated. Okay, so your platelets take about 14 days to repopulate in your system, and not like you're replacing every single platelet every 14 days. It's obviously a little bit at a time, but any platelet that has been coated essentially in aspirin is going to be ineffective until it is ultimately replaced. Relative contraindications for aspirin. I know BLS kind of harps on this, that a GI bleed is like, you don't give a patient aspirin on my desk. But in the grand scheme of things, what's going to kill them first? A slow GI bleed or their heart kind of exploding from an MI? Risk-benefit analysis there. Also, younger children, they don't recommend giving it to aspirin. I think it's like under 6 because it can cause Ray's syndrome, which is a whole other book of, box of worms, bag of worms, worms. There's worms. So it will pass into the breast milk, which is troublesome for kids who are breastfeeding because, again, it increases their risk of Ray syndrome. Asthmatics can have some caniforms. Thank you. I was mixing my bag of cats, bag of cat worms. So you might have a patient who has asthma, who has an adverse reaction to aspirin, but again, we can handle that, right? If they start having some sort of bronchospasm or wheezing secondary to aspirin, we can fix that problem. If they are having an active MI, you don't want to not give them aspirin unless they are actually allergic to it. Oh, I take that back. Adenosine is not in your weapons of mass destruction. It's atropine. I'm having a stroke today. I am so sorry. Disregard that. Atropine is your weapons of mass destruction medication. My bad.
Too bad.
So bad. This super coffee? Not super. It's just kind of okay coffee at this point. All right. So when you have adenosine on one side, which is stopping the heart, atropine helps speed up the heart, okay? Which is why we use it in GOP, in the discretionary order for weapons of mass destruction, because they want to help increase the heart rate during an organophosphate poisoning, right? You end up with your sledgem, everything starts slowing down. Organophosphates highly influence the parasympathetic nervous system. So atropine blocks the parasympathetic nervous system, right? Organophosphates are like, yes, feed and breed, sleep. Whereas atropine's like, no, we're going to block that. So it helps increase the heart rate. Pretty much all you really see it. Only where you'll probably use it the most is going to be in your bradycardia protocol. But again, I have not seen atropine be highly effective in anything really other than sinus bradycardia. Your patient also needs to be symptomatic for this, okay? Like if they're, a heart rate of 40 and their blood pressure is 110 over 60, you're not treating that, okay? You're not going to give them medication for that. So you just need to kind of keep an eye on that. Again, if your patients are kind of going into that lower heart rate range, you're going to start considering atropine, or the heart blood pressure range, sorry. There is a very fine line between atropine and transcutaneous pacing, and we're going to talk about this more in cardiology. But if you look at the protocol is like, okay, symptomatic bradycardia, give them a 250 bolus of fluid, because you want to see if you can help increase the output of the heart by increasing your preload. Again, cardiology, we'll talk about it more. That doesn't work. Cool. Give them atropine, and your atropine dose is 0.5 milligrams. I swear, I feel like I'm covered in ants right now. It's 0.5 milligrams. I believe they've just in the protocol they've increased the overall dose that you can give up to 3. But if you give them 0.5 milligrams of atropine and it doesn't really do anything to their heart rate, and it doesn't really do anything to help improve their blood pressure, personally, I'm not going to sit around and be like, well, maybe the next dose will work. Maybe they need a little electricity, okay? Maybe you need to just, take that step and say, yeah, we're going to make sure we fix this, because you really have a limited amount of time with the patient before that, like, hypotension really starts to affect them in a larger scale. So just keep that in mind. Atropine is also not particularly useful in third-degree heart blocks. You still have the opportunity to use it. It's in protocol, but your higher degree heart blocks, again, we'll talk about in cardiology, don't necessarily respond great to atropine. There's something else going on that atropine's not going to fix. All right, calcium chloride. Calcium chloride you will see this in your cardiac arrest protocols as a medical control option. And when you call medical control, they will almost always give you this option. The thought behind calcium is that the more calcium you have in your bloodstream, the more muscle can contract. And primarily, we're hoping that cardiac muscle is going to be the one that's contracting more powerfully, especially in cardiac arrest. Okay. So you have a patient, they're dead. Maybe they're in VFib, VTAC. You give them all these things, and like epi's kind of working. You want to increase you're attending to your H's and T's, which one of them could potentially be hypocalcemia. So if their overall calcium is too low, their heart can't pump effectively because it just doesn't have enough oomph behind it. You will also see this as a discretionary order in patients who have a beta blocker overdose, but again, you'd have to call and ask. A lot of the times, because you are using calcium chloride primarily only in cardiac arrest, you really don't have to worry too much about the contraindications. Okay, you're not going to be over there with an iStat checking what this patient's calcium levels are. It's not a thing really. While they say do not use this routinely in cardiac arrest, for the most part in the city, if you call for orders and you're saying, hey, like for example, I had a cardiac arrest early on Friday. Hey, I've got a 45-year-old male. He's in asystole. He's been in asystole for 30 minutes. Family says he's been down for 30 minutes prior to our arrival, so he's been down for an hour. Doc will say, all right, give him a gram of calcium and 2 amps of bicarb and call me back in 5 minutes. Because it's sort of like throwing the drug box at it and saying, well, maybe something else will help. It doesn't usually. You do 100% need to make sure, though, if you are administering calcium chloride, you need to make sure your line is flushed if you're also giving sodium bicarb, okay? Sodium plus bicarb plus calcium chloride equals chalk. You will end up with just chalk in your IV line. You're not helping anybody, and then you need a whole new IV line. So just keep that in mind. Make sure you have a copious amount of fluid. Cardiac arrests, usually we hang a liter bag and let it kind of run KVO. This might be you push calcium, you open it wide open, let it flow, drop it back down, then push the bicarb, okay? Or vice versa, depending on whatever you grab first. Order of administration does not matter. Just make sure that you do flush the line out. Questions, thoughts, concerns? Cool. All right. So, diltiazem, aka cardizem, is a calcium channel blocker. It also has the effect of increasing vasodilation. Okay, so what this does is it prevents that calcium influx into the heart, which prevents it from, we just talked about calcium, right? All that calcium helps the heart pump very, very strongly. Diltiazem prevents that. All right, so it prevents that influx of calcium, so the heart doesn't really overdo it when it pumps, which thereby reduces the amount of oxygen that the heart needs. We use diltiazem in our AFib, A-flutter protocol, okay? Find me. So it's an AFib, A-flutter protocol, and it helps reduce the reaction of the ventricles to the overstimulation from the atria. Okay, and again, we'll go into some of this a little bit more in depth in cardiology, but this is like your introduction. Understand what the medications do. So it's going to slow the heart rate. Okay, right? So if you're in a AFib, A-flutter, RVR means rapid ventricular response, by the way. If you're in a really rapid heart rate, you want to slow it down. So that's why we see your amiodarones and diltiazem in your fast, because they are slower. They slow the heart down. Cardizem needs to be delivered slowly, okay? Because if you just slam that in there, you're going to cause their blood pressure to tank, okay? So make sure that, and this is one of those things where you have maybe, 5 milliliters of diltiazem drawn up. You'll push a milliliter, let it flush. Take your time. Push another milliliter, flush it through. Maybe take blood pressure. Push. Right? So you're taking your time, okay? I see a lot of people, they're like, I did it real slow. Not you really, you have to be patient. I know you really probably aren't familiar with Wolff-Parkinson-White syndrome yet, and that's totally okay. But cardizem is usually not used in those patients. Let me see if I can do a doodle. Again, we're not in cardiology yet, but let me do a doodle for you. So I know we really didn't do this yet. I sent you that little so you have your normal EKG, right? In Wolff-Parkinson-White, you have what's called a delta wave. So you have a P wave, and then it just goes straight up into the Q, and it has this kind of slur. Oh, Jesus, I moved the whole thing. You have a slur right here. That's indicative of Wolff-Parkinson-White. So that means that there's an accessory pathway in the heart. So you have oh God, I don't know what I did. Son of a. All right. So you have an accessory pathway in the heart. So where you have your SA node, let me draw. You have your SA node and you have your AV node. There's a pathway that bypasses this normal path and goes right down into the ventricles. So that's why you get that slur. So if you are in the if you are reducing the other, like the pathways through the AV node, you're leaving that accessory pathway unattended to, so it will cause a heart rate increase. Dopamine. Dopamine is falling out of favor, I think, in a lot of our areas. It's falling out of favor because now we have push dose epi, which is very effective, and we have Levophed, which is also effective. The problem with dopamine is that it's weight-based. And just because you are giving a patient a weight-based medication and expecting certain effects doesn't mean that everybody's body works exactly the same. So if you look here on the side, the effects are, it says we have the effects are dose dependent. They love to ask questions about this. This is something you should know. So your 1 to 5 micrograms per kilogram per minute usually affects the renal area. Okay, so that means that it's going to increase your the blood flow to the kidneys. Not really what we're looking for necessarily. What we are usually looking for is the 5 to 15 mics per kilogram per minute, because we usually use dopamine to increase blood pressure. And then you also have your higher doses at 20 to 50 mics per kilogram per minute, which causes peripheral vasoconstriction. So just because I'm giving a patient 15 micrograms of dopamine doesn't mean that their body doesn't decide, I don't want to be in cardiac anymore. I'm moving over to vasoconstriction. It also doesn't mean that you don't have renal effects. So it's not a perfect science, which is why you see a lot more push for the push dose epi and for the Levophed or norepinephrine. It's a little more precise on those two medications. Dopamine is really good. It's a really good vasopressor that it does increase your myocardial contractility and the stroke volume. So it's making that heart beat harder and push more with every beat. We use it in our cardiogenic shock protocols. It's also in your septic shock protocols. Levophed is the preferred vasopressor for septic shock. There's a lot of research that backs that up. Hypotension with low cardiac output states is also, so like, you know, there's a number of different things that could cause it, but we do not use vasopressors in hypovolemic shock, because then where's that blood going? The problem with hypovolemic shock is not that the heart's not pumping hard enough, it's that there's not enough fluid in the chamber to be pushed around. So just keep that in mind. This is a medication that you have to mix on your own. And I know I had the group that did the review the other night. We talked about this really quick. Dopamine comes in pretty standard doses. So you can put 200 and 250. Maybe. This is the worst annotator. You can put 400 and 250. And you can put 400. Oh, Lord. This annotation sucks on this one. Zoom is so much better. It's 400 and 500. This is 800 mics. Milliliter. No, I did that wrong. I did that right. This is 800 mics. And this is 1600. Don't mind my terrible. All right, so this is your standard dosing that you have. I don't know what's worse, my work ants, the annotator on here. Those are your standard doses, all right? If you memorize those doses, you'll never have to do a dopamine math long division ever again. But that means you need to make sure you've memorized them. Just a suggestion. It will make your medic life a little easier. So those are the standard doses that we see for dopamine. These are your, I don't think the protocols are numbered the same anymore. But you'll see it in your cardiogenic shock, septic shock, protocols. I believe it's also in your bradycardia protocols because you can use it to help increase the cardiac output. Dopamine should be run on a dial-a-flow. It needs to be run through a large bore IV, an 18 or better. Any vasopressor that you use should be on an 18 gauge or larger IV. And they should be used with dial-a-flow because it should be relatively precise. We don't have IV pumps. Well, maybe one day when they're less expensive, but it should be done to some level of precision because you don't really want to like screw with the patient's body too much. You also should make sure that the vasopressors are administered into a large vein, okay? Because if you put a vasoconstrictor into a small vein, you might shut that whole vein down because it's going to have a lot of potent effect right at the end of that IV, and it's not going to get to the rest of the body. Epi, super popular medication. We use this for a lot of things. Epinephrine or adrenaline, right? It's the same thing, is an agonist of the sympathetic nervous system. So it increases your heart rate, it increases your heart's contractility, and it provides certain level of peripheral vasoconstriction. The problem is beta blockers might blunt the effects of it. Patients also end up with like relatively decent tremors and like nervousness if you happen to end up using it on a live patient. Most of the protocols that you see here for the 1 to 10,000, which is the cardiac version of epi, is in cardiac arrest. You can use push dose epinephrine, which I'm going to get. Hold on, let me see if I get this little crappy annotator back. So for your epi 1 to 10,000, it's 1 milligram in 10 mLs. Okay, right? That's your standard dose for epi 1 to 10,000. To make push dose epi, which you also can use in these protocols, mostly the cardiogenic shock one, septic shock, you can also see push dose epi, you're putting 1 milliliter, which is 0.1 dot. I want to dot. I swear to God, this annotator, we're going to fight today. You're putting 1 milliliter of, which is 0.1, imagine there's a point there, milligram of epi into 10 mLs of normal saline. That's actually 9 mLs of normal saline for a total of 10 mLs, right? So you're using maybe like a flush. You push out 1 ml, you draw up the epi. This gives you epi 1 in 100,000. I'm not going to fight this little annotator today, right? Okay, so this means that you're now, every time you give the protocol for push dose epi, is that you're giving 1 ml of 1 in 100,000, which means that you're giving 0.001. Okay, it works great from what I've heard. I haven't had an opportunity to use it yet, but everyone I know who has used it says it's fantastic. It does a really good job, and it's a lot easier to manage than setting up a drip. The problem is, 1, make sure you label your vial, your syringe. 2, make sure your partner doesn't push the entire thing. That's a lot. Contraindications for epi, 1 to 10,000, hypertension, right? You don't want to make it worse. Hypothermia, that blood is not going to be moving around, so you don't give epi in a hypothermic cardiac arrest. And pulmonary edema, you're just going to strain that heart. Most of the time, pulmonary edema is caused by a cardiac issue. You're just going to flood the lungs with more fluid, and it's not going to be pretty. Questions, thoughts, concerns? How we doing? Everyone still with me? Didn't lose anybody?
I lost video.
That's fine, as long as you respond.
My video, for whatever reason, is not working.
I think it's just a bad internet day, honestly.
Got it.
That's all right. All right, so furosemide.
Nicole, I just have one quick question.
Yeah, go ahead.
I noticed you're skipping some of the medications from the homework.
Yep, we're doing it by category, not alphabetical.
Oh, okay.
Yep. Oh, don't worry. This is a relatively long, we'll get there. We'll get there. There's going to be some that we're going to kind of gloss over. But we'll get there. So yeah, so furosemide, this is one that we're going to kind of gloss over. This works in the ascending loop of Henle. Might be something you remember. It's really good for trivia night. Basically what it does is it helps increase your urinary output. It's a diuretic. There's the word I'm looking for. It is not standing orders. Okay. The primary consideration with furosemide is we usually use it in your APE protocol. You can't push furosemide fast because you'll give this person permanent ringing in the ears and they will hate you forever. It should be used in caution with patients who have kidney dysfunction. So if their kidneys aren't working and then you overload them with fluids like the furosemide to try to help make their kidneys work better, you're not going to do much of anything except cause a little kidney damage. The problem with Lasix is, go ahead.
Why does it cause ringing in the ears?
It's just if you push it too fast, it just is toxic to the ears. It's just one of those quirky medication problems. I'm sure if you wanted to go in a deep dive of the internet, it could probably tell you. I don't know the specific mechanism of how it does it. I just know that you shouldn't push Lasix fast. Frankly, unless you have an extended trip to the hospital, I wouldn't even bother calling for Lasix. It is, again, it's one of those medications that's falling out of favor. It's one of those, it's falling out of favor because it takes about an hour for it to really start working. And we have CPAP now, and CPAP works within a minute, 2 minutes in improving patient oxygenation. So it's really not something that's like kind of sticking around or is really popular. I could honestly not tell you the last time I pushed furosemide. Another concern is that is the patient actually in APE or are they in pneumonia? Because if they're have pneumonia instead of just pure genuine fluid, they have consolidation with bacteria, and you reduce the fluid in their system by using furosemide, you've just turned that bacteria gunk that was like maybe loose and mucousy into cement, and their lungs will never be the same. It's not worth it. Let them take a chest x-ray first, let them figure out what's the deal, and then go from there. Lidocaine. So while lidocaine is a class 1 antidysrhythmic, which means that it blocks your sodium channels and decreases how fast the electric automaticity of the heart can travel, we actually really only use it in protocol for pain management of the conscious IO. Lidocaine does seem to be coming back into favor, though, a little bit in terms of for cardiology, for use of VFib, VTAC. You're most likely not going to use it within your time in paramedic school as an antidysrhythmic. It is something that you should know for the national, that it can be worked there, but in the city, we only use it for pain management. So we're moving on. MAG. It can be used to an alternative for amio, yeah. Again, not in the city, not in our current protocols. Other regions might have it in, because amiodarone, remember, duct tape, if you have a patient who's in VFib, VTAC, they have too much electric going on, lidocaine mutes that so that the normal pacemaker can hopefully take over. Good question, though. But yeah, again, not something we're going to go too heavy on right now. Mag sulfate. We're going to talk about it in two forms right now. So one, mag sulfate is indicated for torsade de poids, turning of the points. It is a polymorphic VTAC, which that sounds like word soup to you, but that's okay. We're going to talk about it more in cardiology. But it has a very distinct morphology on the EKG. Again, we'll learn it in a bit. And MAG is the the solution for it, okay? It is considered a muscle relaxer. It is the opposite of calcium. So while calcium's over here going, yes, we'll pump strong, mag is like, chill out, bro. Okay, so they kind of counteract each other. You never want to use mag in a heart block, or if you have a patient with significant myocardial damage, you're really only ever going to use it in torsade de poids for cardiac. It's 2 grams is your dose. In your cardiac protocol, you're going to dilute those 2 grams, which is about 2 mLs, in 10 milliliters of normal saline. Okay. If your patient is in torsade de poids, which is just fun to say, you're going to be bolusing it. All of your electrolytes, mag, calcium, burn when they're bolused. That's why we dilute them. But if it's not a drip, it's still going to burn. Okay. Hopefully your patient is dead-ish, not a fully dead, but to the point where you can actually maybe get them back. So they'll forgive you if you burn them a little bit with the mag. It is a discretionary order, so you'd have to call. If you called and said, "Hey doc, I've got a patient in torsade de poids, I want my mag," they're not going to give you a hard time. They'll say okay. So, excuse me. We also see mag in eclampsia, preeclampsia protocol. Okay, again, we don't know exactly how mag works on preeclamptic or eclamptic seizures. Very unclear science, but we just know that it works. That you put 2 grams in 100 milliliters, okay, and that's a drip. Again, same thing, you have to call for it. You're going to be calling and saying, hey, I have an 8-month pregnant female who's been seizing for 10 minutes. I need my mag. And they're going to say, okie dokie. So just keep that in mind. You also will see mag in your asthma protocol as a standing order. The only protocol that magnesium sulfate is a standing order. Keep that in mind. The thought is, again, not an exact science, but they think that mag works to relax the bronchioles, okay, and help increase bronchodilation. Usually it's only in patients who are in severe respiratory distress, and you'll get to the point where you're like, this guy needs it. I'm really paranoid that I'm covered in ants right now. Anyway, nitro. Nitro is your main pain management medication for patients with chest pain. Okay, not narcotics, not Toradol, not any of that. Nitro. Nitro dilates the blood vessels, mostly the veins. It also relaxes the smooth muscle. It works very quickly. One of our only sublingual medications. What you're going to see with nitro is that you'll maybe have patients who have chest pain and they're taking their nitro and it's not working. Their nitro is probably old, okay, or it wasn't stored properly. Or there's a third option where their cardiac arteries, their coronary arteries, have tried to accommodate for the blockage. So say this is your coronary artery. They had this little thing. If this is all blocked, and that's the only area that blood can get through, the vessel's going to try to dilate, right? It's going to try to come out here and be a little bit bigger to get as much blood flow to the heart as possible. If you take nitro and that blood vessel is already dilated to its maximum, you're not going to necessarily see the most pain change response, the best response, because their heart vessels have already done everything they can. They have removed ED medications from the protocol as being a contraindication, but you should still make sure that you ask the patient if they've taken it. It's one thing if the patient's taken erectile dysfunction medication within the last hour or 3 days and their blood pressure is 80/40 versus 180/140. A patient whose blood pressure is particularly high and you're giving them nitro, you're not going to necessarily tank their blood pressure. You're going to be a little bit safer. We also use nitro for APE because what it does is it kind of helps redistribute the fluid back into the blood vessels and out of that interstitial space. We're going to talk about that more in cardiology, so don't stress about it too much. But this is in your suspected MI protocol. Norepi, and or Levophed, and or leave them dead. You have to be careful with norepinephrine, because if you start a patient on the Levophed drip and you happen to run out of Levophed, their blood pressure is going to tank almost instantaneously. It has a very short half-life, okay? There have been many a story of transport medics taking a patient on Levophed drip, getting stuck in traffic, and their patient dying because they ran out of Levophed. Just something to take into consideration. Most of the time when you mix norepinephrine, you're putting 4 milligrams in, I believe it's 100 milliliters, 250. It's a 250 bag. So you're putting 4 milligrams in a 250 bag for a concentration of 16 mics per milliliter. Okay, this is your standard dose of norepi. Norepinephrine is primarily an alpha-1 agonist, so it constricts the peripheral blood vessels and then shunts everything back towards the heart, which is how it gives you nice blood pressure support. It also increases the heart rate and heart contractility a little bit, but for the most part, it's used for its vasoconstrictive properties. This is why it's so effective in septic shock, because the problem with septic shock is you have very loosey-goosey connections between your blood vessel cell walls, because the bacteria toxins are just like punching holes in things. So this is why we like it there. As with any other vasopressor, you need to make sure that your line is super patent before you start administering it, because you will 100% cause necrosis if it is a blown vein. And then your patient's got bigger issues to deal with. Again, pressors and hypovolemia don't mix. So make sure that the reason that your patient is hypotensive is due to a heart issue or a sepsis issue, and not a fluid issue. Most of the time, we like to give a little bit of a bolus in your shocky patients to see if it supports their blood pressure. Septic shock patients benefit from boluses of fluid. Cardiogenic shock patients, depending on what side of the heart is really the most effective, sometimes increasing that free load with a fluid bolus can significantly help their cardiac output regardless. Bicarb, this is again only really seen in cardiac arrest as a discretionary order. It can also be used in severe metabolic acidosis states, like you'd see in a tricyclic antidepressant overdose, aspirin overdose, or diabetic ketoacidosis. Okay. Again, you're going to be calling medical control for these, so they're not necessarily going to be giving this to you. Maybe for a tricyclic antidepressant overdose, amitriptyline, I'm gonna write that down on the top so you know, is like one of the only TCAs that are really kind of popular anymore. Keep doing that. There we go. Okay, I know that's absolutely ridiculous. Amitriptyline is one of the still commonly used tricyclic antidepressants. The problem with tricyclic antidepressants is that the patient will go into VFib and then into cardiac arrest. Just boom, just straight down. Again, make sure that if you are using bicarb with anything else, you make sure the line is flushed very thoroughly after administration. Oxygen. I don't think I need to explain oxygen to y'all. Does anyone need a brush up on oxygen? Just do me a favor, if you have a patient who is, especially cardiac patients, if you have a cardiac patient whose SpO2 is 99%, they're having an MI, but they're not short of breath, they're not complaining of anything, you don't need to bump them up to 100. You don't need to put them on a nasal cannula. That's okay. There has been significant research that supports oxygen toxicity causing reperfusion dysrhythmias, which are actually more deadly than you not putting your patient on 2 liters nasal cannula. Okay. You can overdose on oxygen. It doesn't help the heart when that clot is removed and now you're just flooding it with high levels of oxygen. Okay. So again, look at your patient. If your patient's complaining of shortness of breath, that patient needs oxygen. If your patient's normally maintained on oxygen, like a COPD patient, that patient needs oxygen. If your patient's chilling on their phone, going, yeah, I'm having some chest pain. Like, I don't know, I'm just having some chest pain. It's not really feeling great. Maybe they don't need it. Okay. There is the consideration that if you put COPD patients on high flow liter oxygen, that you're going to decrease their respiratory drive. Maybe. If they're short of breath, I don't care. I want them to be able to breathe. I want them to feel better. I'm just going to keep a close eye on them to make sure that they're not getting, a bradypneic is the word I'm looking for. Any questions? That pretty much sums up our cardiac medications.
I have a question, Nicole.
Go ahead.
So like in terms of like just care, just like I don't know, like are you also so when you're at the scene and you're treating this patient, like are you also thinking about those long-term effects, or you just like straight just thinking about the present issue? You know what I mean? Like
Yes, I do. I 100%.
does that interfere with kind of like what you want to do, or like you know what I mean? Like so.
Yeah. Yes and no. So the more you know, the better your patient care can be. This is why I will always be a proponent for like constantly doing CMEs and learning more. The problem is you also need to make sure you're still working like within your protocols. Your protocols say that you're going to, give your oxygen as per your patient's symptoms, and you're going to gear your oxygen therapy appropriately. So that means, like, again, we teach BLS, everyone gets a non-rebreather. No, like, I think everyone can kind of like is at that point right now in their careers where you kind of realize that not everybody gets a non-rebreather, because not everybody needs it. But as you start to learn more and you get a little more information, like you'll start to kind of know the lines that you need to color within and when you can step outside them. So things like intubating a patient, right? I feel like that's probably one of the most significant long-term things that we do that could affect the patient long-term. So if you have a patient and you're like, yeah, I'm not sure, let's intubate them, but you're managing them fine and BLS, they're kind of with it still. I don't know. Like most of the time, like I would say I'm relatively aggressive when it comes to managing an airway. I see somebody and go, oh, they're getting tubed. But sometimes, if the patient's awake enough where you can give them CPAP, you're going to potentially reduce their hospital stay significantly. Especially as you get into the elderly patients. 1 day in the hospital, they lose 3 days of function. So you're reducing their like vital capacity pretty significantly. Because think about it, you're stuck in bed, or you're in a chair, or you're in bed, or you're in a chair. The elderly population needs to keep doing their ADLs. This is why a lot of elderly people are concerned about going to the hospital because they're afraid they're never coming home. That's fair. Like I sympathize with that. But yes, I do think to a certain extent we need to kind of make sure that we're thinking about long-term effects. There are definitely going to be long-term effects of stuff that we have no control over or we have no necessarily vision of, and that comes with experience and ongoing education. But there's certain things that I think you really do need to know from the start, like IOs. Can you get an IV on somebody? Maybe. If you can't, maybe they do need an IO. But you're increasing the risk of an infection. You're increasing the risk of that bone potentially having an issue in the future because you're now putting a hole in it. So, do I want to do this? Do I need to do this? Can I manage this patient without it?
Like, do the pros of the intervention outweigh the risk of the whatever?
Yeah, 100%. I think we need to. That's the human side of medicine, if you really think about it. Like, I can teach you all of the clinical aspects. I can teach you what these medications do, and I can teach you all that stuff, but I can't teach you to be compassionate. I can't teach you how to look at a patient and say, oh, all right, listen, I'm not going to go for that IV again. I've already stabbed you twice and I can't get one. I'm not going to jab you again. I can't, I can't. You'll learn. You'll learn. And I think part of the problem is you need to also make sure that when you're doing your ride time and you're doing even just in your career, the people you work with, that you don't let the salty, jaded people affect you. Like, remember that you're in it to help others. You're not in it, to be mean.
Just make money or whatever.
Just to make money. Yeah, a lot of people get burnt out, and that's really unfortunate. But that doesn't mean that it has to change you. Your job is a patient advocate, first and foremost. So if you see something you're not really okay with, say, hey, that's all right. How many times you have a partner who tries to shit can a job, says, you don't need to go to the hospital. Like, they want to go. Let's just take them, right?
Yeah, not wanting to put them on a stretcher or something like.
Yeah, or they're gonna walk them to the truck, and you're like, no, we're not walking it. Put your foot down. I've done it. Put your foot down. No, go get the stretcher. Do the right thing. So sometimes it's a hard situation, but I think 100% thinking of the long-term stuff sometimes is important. Sometimes you won't know what those long-term effects are. Sometimes you're going to just know, I need to get an airway in this patient. That's it. Or they're going to die. So
I also have another question.
Go ahead.
This is a little bit. But how do you know, let's say for example you have a situation and you have to give adenosine or something, but you're like, damn, I don't know, this person's kind of old, 90, what if they don't come back? But the protocol says use adenosine. How do you just gotta back that up in your PCR kind of thing? How do you even
call medical control? Hey, I have a patient who's an SVT. She's 90 years old. I'm a little concerned about giving her adenosine. You have another option? I'm worried that this adenosine's going to take her out.
She won't even come back or something.
Yeah, 100%. If you ever have any concerns about something, you can call. I had a patient. Guy was in a heart rate of 190, but he was in DKA and he had other things going on. Gave him about 250 milliliters of fluid. The heart rate started coming down, and I didn't want to give him adenosine. I called medical control. I said, hey, I don't think, I just want confirming. This is what I have. A patient who's, they're vomiting up blood and they're in DKA, and I think it's really a fluid problem more than a heart problem. I gave them 250 bolus and the heart rate started to come down. I'm starting my second 250 bolus. I do not want to treat. Is that okay? Yeah, I agree with you. Sounds good. Have a nice trip to the hospital.
Oh, got it. That makes sense.
Yeah. So as I like to say, let someone with way more school debt than you make the ultimate decision. If you have any concern, call. But have a reason that you're concerned. Don't just be like, I don't know, something's not right. If you can back it up, you're never gonna have a problem.
That's cool. Thank you so much, Nico.
You're welcome. Any other questions? All right, cool. Albuterol, your primary respiratory med. You all should be pretty relatively familiar with this, I think. Albuterol, right, is a beta agonist. It relaxes a smooth muscle and causes bronchial dilation. We use it in our anaphylaxis and our asthma/COPD protocol. The only contraindication is a hypersensitivity. Especially now that you're moving into the medic realm, you don't have as many limits on how much medication you can give as you do on the BLS side, because you will be doing cardiac monitoring. Okay, when you're not doing cardiac monitoring, there's always the concern that the patient's going to have some sort of dysrhythmia, and if you're a BLS provider, you won't understand or be able to identify that. So a lot of that kind of gets removed a little bit. Please, though, pretty please, do me a favor. Do a good assessment first. Get some vitals first. I can't tell you the number of times I've seen patients who are in APE who have diffuse wheezing because of fluid, given albuterol, and then flash over and are really full of fluid. Okay, just because a wheeze is wheeze does not necessarily mean that it is asthma. So just keep that in mind. Make sure you get a good set of lung sounds. Make sure you get a blood pressure. Any sort of blood pressure that's like highly elevated, I would kind of lean more towards APE. The nice part about your asthma protocol is it also gives you the option of putting the patient on CPAP. So if you're putting that patient on CPAP, second. You're again, CPAP is a duct tape of respiratory problems. It does a lot. It can help you keep having to tube a patient, reduce, hospital stays. If there's any sort of doubt as to what that wheeze is, it could help. Dexamethasone and or Decadron, okay? We use this again in our asthma protocols. We use this in our anaphylaxis protocol. What it does is it stabilizes the cell wall primarily in asthma. Okay, so what it's doing is it's making sure that mucus influx doesn't happen. Okay, right? So asthma has 2 stages. We'll talk about that more in respiratory, but it keeps all those cell walls in the airway stable, because once they start getting unstable, they start leaking, and then fluid gets released into the airways. Not a good look. And in anaphylaxis, what it does is it suppresses the immune system. Okay, so when it suppresses the immune system, it reduces inflammation. All of that swelling is reduced. Okay, because again, remember, anaphylaxis is an overreaction of your airway, of your immune system. Again, dexamethasone and solumedrol or methylprednisolone, pretty much the same concept. Depending on which agency you're for, they're both glucomineral steroids. Are used in the same realm. Okay, your dexamethasone is 12 milligrams. Your solumedrol or methylprednisolone is 125 milligrams. Both of these medications also could potentially be used in sepsis to help, again, stabilize those cell walls, because one of the problems with sepsis are leaky cells. But you have to use them with caution, because it will also reduce the immune system, so your white blood cells aren't going to be as productive. Diphenhydramine or Benadryl, okay? This is used in your anaphylaxis protocol, as well as your lesser allergic reactions. So if you have somebody who's a little itchy but doesn't have the angioedema yet, diphenhydramine is your magic. It is a H1 receptor blocker, okay? So your H1 receptors are all throughout your body, whereas your H2 receptors, which are those also histamines, are primarily in your GI tract. That's when you start giving a patient like Pepcid. We don't give Pepcid, not yet. So basically it starts to reduce the H1 receptors, which means it's reducing the effect of histamine. So it's reducing how powerful the allergic reaction can be. A lot of times we try not to use it in asthma. Pregnancy is also an issue. Drowsiness is the primary side effect of Benadryl. So you want to this is why we don't use it in kids, okay? It also will have some antiemetic properties because it does generically works on the H1 receptors that also happen to live in your GI tract. One cool thing that Benadryl does also is it treats what's called a dystonic reaction. So dystonic reactions are a response to antipsychotic medications that cause these like hardcore tonic-clonic or just clonic contractions of the muscles. Okay, they're relatively painful. You'll see a twisting of the neck. The patient won't be able to move their head. It might go all the way down through their back, right? So they might be arched and they're not able to move. They're there. It looks like they're almost seizing, but they're there. They're awake. They can like kind of look around. Benadryl does amazing work on fixing that reaction. Again, it's some seizure medications, some antipsychotic medications can cause a dystonic reaction. I've seen it and used Benadryl to treat it once. And it actually worked really, really well. Because we couldn't get a line on this lady. Like literally, we had the laryngoscope in her airway and she woke up. I'm like, what's going on? So other medications that we use for airway is your Epi 1 to 1,000, right? This is the one that comes in the little vial. You're going to be giving this one IM, okay? You can nebulize it for croup or severe asthma attacks as a racemic epi, but you'll end up diluting it with some saline for the into the nebulizer. It blocks histamine. It is an alpha agonist, a beta agonist, relaxes smooth muscles, right? Does all the things that Epi 1 to 10,000 does, just a little faster because it's a little more concentrated. We want this to work fast because we're using this for anaphylaxis. We also can use this in severe asthma in our protocols, but that's not new from BLS, right? BLS, you can still use Epi 1 to 1,000 in a severe asthma attack, right? You have a patient who's barely moving air, maybe their silent chest. This is your fix, okay? Again, beta blockers are potentially an issue. You want to make sure that you have the right dose, right? So adults are 0.3 milligrams and children are 0.15. If you're using the check and inject method. Kids, you actually will use, this is weight-based for kids. It's 0.01 milligrams per kilogram for children. So you're kind of fine-tuning the medication a little bit for them. New nebulizer medication that we start to add again as medics because we have the ability now to cardiac monitor. Ipratropium bromide and or Atrovent. Okay, so you have your albuterol, right, which is a beta agonist. Atrovent is a parasympathetic blocker. Okay, so now they're doing the same thing, but working on opposite sides of the nervous system, right? So if you have too much parasympathetic effects, you're going to have the bronchial constriction. You're going to have a increased mucus, right? That's what ipratropium is preventing. Whereas albuterol, which is your primary emergency medication for asthma, albuterol increases dilation by stimulating your beta receptors, right? So they work in conjunction. They're a nice team. Ipratropium will clear up secretions a lot better than albuterol, okay, because it is working on that parasympathetic nervous system. It is thought to have a lot of ipratropium was made with soy, so soy allergies were an issue with ipratropium in the past. I do believe that most ipratropium is no longer made with soy, so that's hopefully less of an issue now. So we talked about MAG again, same thing, but we use it as a seizure of eclampsia. I copied the slide from I pulled it to the wrong spot. You are going to use this as a standing order in your asthma protocol. You want to make sure that you're diluting this, okay? You're going to be giving it a drip. It's usually in 100 milliliters of normal saline over 10 to 20 minutes, okay? It's a muscle relaxant, so it's going to relax all those bronchial muscles. Methylprednisolone, we're going to just kind of not go too deep into this, same as dexamethasone. It really just depends on what your agency carries. Dexamethasone is a smaller dose at 12 milligrams versus 125. It's more potent. It is thought to work better, but it's much more expensive, okay? Methylprednisolone also has some impacts, supposedly, on the inflammation of spinal trauma, but it needs to be done within 8 hours. Most of the time this happens in the hospital, and that's at them. We do not have a protocol for it, but it could be used as a discretionary order if you're feeling spicy that day. Racemic epinephrine, this is a purely discretionary order. It's just something good to know about. If you have a patient, especially pediatric patients who are dealing with croup, you can take a racemic epi, which again, no one carries racemic epi on the ambulance, but you could take your 1 to 1,000 and dilute it with some saline. Group super severe asthma, this can help reduce airway resistance because it works just like IM epi, but it's going right to the target tissues, so it's a little more effective. Discretionary order only. Terbutaline. I have never, ever seen terbutaline on an ambulance. They love this medication for some reason because it is both oral and or inhaled. It pops up on tests all the time as which medication is which of these respiratory medications can be administered orally and via inhalation. It's terbutaline. I couldn't tell you anything more about that. They use it for asthma. That's all you need to know. You can use it either way, oral or inhaled. There's your state test question. Enjoy your 1 point. Questions, thoughts, concerns, recipes, Beatus.
Quick question, Nicole.
Quick answer.
Is the next exam gonna be on chapter 14 and 13 plus all of the meds, right? Like, is it gonna involve like the contraindication and all that stuff?
I don't believe it's going to go that deep. I will look at it and I'll let you know.
Got it. Thanks.
I don't think you need to go that deep though. You should be very familiar with your medications though by the end of
section. Yeah.
Oh, again, most of the contraindications, there's nothing super special about the contraindications. Primarily, it's like you don't want to give epi to a patient in APE. You don't want to give an A medication to someone who's allergic to it. You might want to reduce. You might want to reduce the the dose of Lasix for patients with kidney issues. It should be relatively easy. I'll look at the exam and I'll let you know a little more in depth though. When is your next exam? When is the next exam, by the way?
The 12th, July 12th.
Okay, so I don't think we have another lecture until July. But we'll do a review. We'll do a review. Okay. I'll schedule that. So don't you all worry, we'll review.
I feel like this exam's gonna be like brolic. It's gonna be dope.
You'll be alright. You'll be alright.
You'll be alright. How are you thinking of go?
Alright with 3 eyes. Alright, anybody else? Alright, cool. Endocrines. Your number 1 endocrine medication. Dextrose. Sugar. That's it. It's sugar. Okay. It's IV friendly sugar. Except, again, just like with your vasopressors, you need to 110% make sure that whatever vein you're putting, especially D50 into, is patent. That IV is golden. Okay. Because if that starts to leak and it extravasates, which goes outside of the vasculature, you're going to cause all sorts of necrosis for that patient. It's going to be a disaster. It's extremely acidic, which causes the necrosis. So just be very careful. A lot of protocols are moving away from using D50 and moving towards using D5W, which is a much more diluted version of the dextrose. Yes, this is exact. And it's also, D50 is very unkind to diabetics. Diabetics like to keep their blood sugar in like this really careful, tight realm. Okay, so like they'll know, okay, I'm going to eat, I'm going to give myself this many units of insulin, and when I eat, it won't go over 200. And my bottom range, I won't go under 100, for example. Right? So they want to keep it here. You give them D50, you're giving them 25 grams of sugar. That's a glass of Coca-Cola. Okay? You're just pumping their system full of sugar, and you're going to take them right up to here. They're going to be like 300, 400. And those big peaks and valleys are not good for them. Okay? It really screws up their system. Because if you think about it, when you have a normal functioning pancreas, you really don't see those really high peaks and valleys. When you do, you get a sugar crash, right? You're gonna sugar crash this patient. So D5W, much gentler, much safer for the vasculature, a lot less, acidic and abrasive on their veins, just nicer. Generally, you want to make sure that you're checking a blood sugar before giving dextrose, because not every single altered mental status diabetic is hypoglycemic. I once watched I had a guy once, he was on like AMS. He had a minor MVA, totally out of it. PD gave him a tube of oral glucose. I don't know where they got the tube of oral glucose from. FDNY EMTs showed up. They gave 2 tubes of oral glucose. By the time we got there, his sugar was 500, but he had a massive brain bleed, so the sugar wasn't going to fix him. In fact, there was nothing that was going to fix him because his whole head was he was just done. He had such a bad brain bleed that he was not coming back from that. So make sure that you check a sugar before you administer dextrose. Your diabetics are also going to be the most common patients who you're going to wake up and they're going to go, I'm not going to the hospital. And you're going to go, okay, let's eat a sandwich then. Okay? Don't drag your diabetics to the hospital. If they can eat and they have food in the house and they just happen to forget a meal, it's very common. It happens every once in a while. Don't argue with them. You know, it's like seizure patients who don't want to go to the hospital because they had a small breakthrough seizure. A lot of times they don't necessarily need to go to the hospital. New onset seizures? Oh yeah. Seizures lasting more than 10 minutes? Oh yeah, bring them to the hospital. But, you know, just know that you're going to probably get some pushback from diabetics who you've woken up with dextrose, and that's totally okay. Glucagon. Glucagon, we talked about this already a little bit at some point, I remember. Also, helps increase your body's blood sugar. However, it is a synthetic hormone. It helps move glycogen stores in the liver into glucose. You also might move glycogen stores in the muscles to glucose. The problem, if you have a fragile diabetic or a diabetic who doesn't take very good care of themselves, they probably don't have a lot of glycogen stores. So the effects that you're going to see from glucagon are not going to necessarily be as dramatic as you really need them to be, because the patients who you're giving glucagon to, because glucagon's IM, so in the event you can't get a line and give D50, the patients you're giving glucagon to are probably the ones you really can't get a line on and their sugar's like 12. You're probably not going to see a significant increase in their blood sugar. It also takes about 20 minutes. So while you're over there stabbing this patient, trying to get an IV so you can give them dextrose, the glucagon may or may not be working. So just keep that in mind. It's a good tool to have. It just might not do as much as you want it to. Don't expect miracles. BLS, oral glucose, okay, must be swallowed. It is not effective if it is just kind of hanging out in the mouth, okay? Again, the whole idea is that it's going to increase glucose levels. You should really be checking a patient's blood sugar before you're administering stuff. If you have the option of giving a patient food as opposed to oral glucose, like a genuine actual food, like a sandwich where there's like protein and carbs and like a whole mix of stuff, much preferred, okay? It lasts a lot longer than the glucose. It's going to get burned off really fast. Same thing with dextrose. You put it in their veins, it's going to get burned off really fast. So they need to eat if they expect to stay home. Hydrocortisone, this is used primarily in Nassau and Suffolk, and I think actually Nassau just took it out of protocol again. Hydrocortisone is used solely for Addisonian crisis. We're going to talk about this when we get to the endocrine system. I don't want you to worry about it too much. It's just something you should be relatively familiar with. It's a steroid, just like dexamethasone and methylprednisolone / solumedrol, okay? If you have a patient who has Addisonian crisis, you give them this and it puts the fluid from the interstitial areas back into their bloodstream so that they have a better blood pressure. A lot of places don't carry hydrocortisone because it's expensive, and they don't use it all that often. So you can use methylprednisolone in place of it, but again, if you're seeing Addisonian crisis and you're working in Suffolk, maybe you'll use it. Questions, thoughts, concerns? Christopher Lopez, I don't have another question from you. Y'all are no fun.
No, I'm trying to think of one, but I don't got one right now.
All right.
Next one.
All right, mag sulfate. As you can see, I flip-flopped these two slides by accident. This is used in preeclampsia or eclampsia. You have to call for mag, which is, you know, kind of terrifying when you have a pregnant patient who's seizing in front of you. The wait is awful, but this is going to be a two-prong approach where your patient is, your partner is starting an IV, making sure this patient's getting oxygen while you're on the phone going, I need mag now. Then your medication is going to be your dose is 2 grams. You're going to dilute it in 50 to 100 milliliters of normal saline. You're going to give it to the patient via IV, and hopefully it will help reduce the seizures. The only treatment for seizures of pregnancy is delivery of the baby. On top of that, a woman can have eclamptic seizures up to 6 weeks postpartum. Okay? Just because she is no longer pregnant does not mean that she can't still be eclamptic. The hormones in her body, the proteins going through the bloodstream, this can cause all sorts of problems. So do not just blow it off because or miss it. This is one of those things. It's like it's one of those state test questions that they like to use. They're like, all right, you have a patient who's 2 weeks postpartum. You get to she received prenatal care. She's home with the baby. She's breastfeeding. Patient says that she's had a severe headache. While you're in scene with the patient, she starts seizing. Patient has no prior history of seizures. That's eclampsia. Okay? Until proven otherwise, unless she's got a brain tumor, that's eclampsia. Okay? So just make sure that you keep your index of suspicion high for any female in that childbearing period, okay, that peri-labor period. Because I've actually was doing the critical care class, and 2 medics from the Midwest somewhere totally missed eclamptic postpartum. So just it makes me sad. And that's your only OBGYN med. We don't do anything else because there's really not much you need to do. We're going to have fun in the OBGYN and labor and delivery sections. The best birth control options I can give you is me terrifying you with all the things that can go wrong during birth control or during birth. All right, sedative meds. Diazepam. Almost no one carries diazepam anymore because there is a shortage. So everyone has, therefore, doesn't carry it anymore. So you might see it here and there. You'll definitely see it in your protocols. But basically, all of your PAMs, diazepam, lorazepam, and midazolam, increase the seizure threshold, okay? And as well as induce amnesia and sedation by enhancing the effects of GABA. GABA is a neurotransmitter in your brain that helps you sleep, okay? So it's just kind of over there, it saddles up to GABA and like, hey girl, how you doing? We gonna make this person real sleepy, okay? Diazepam is IV only, as opposed to Ativan or rectal. Ativan, which is lorazepam, and midazolam are IV, IM, and IN. Okay, so you can also shoot it up a nose. Keep that in mind. So your standing orders, right? You're going to be seeing this in your EDP protocol, not diazepam, just in general, your PAMs. You're going to see it in your EDP protocol. You're going to see it in your seizure protocol, and you're going to see it in your sedation protocols for post-intubation. You just didn't have a stroke. Post-intubation, cardioversion, and pacing. Okay, those are where you're going to see your sedatives. Okay. Again, no one that I know of carries diazepam anymore. I used both of the final vials of diazepam at Jamaica back in the day, on the same day, ironically. I'll tell you all that story another time, maybe on the 7th. Etomidate. Etomidate is not really a benzodiazepine. It's actually, they classify it under there, but it's more of a sedative hypnotic. Okay, it causes the patient to kind of dissociate and have and the muscles to relax. This is what we use for intubation. They also, it's in protocol for cardioversion. Okay, not pacing, cardioversion. Because cardioversion is hopefully it's a one and done. Etomidate is relatively short acting. Pacing, you're going to have a patient going to the hospital getting electrocuted once every, for a heart rate of about 80. That's a long ride if that etomidate wears off. If you are intubating a patient, you should be pairing your sedative hypnotic. Etomidate is your only option as a sedative hypnotic pre-intubation. You should be pairing that with a benzo. Okay, you should be sedating and amnesia-ing your patient because you don't want them to wake up going, I remember you sticking a tube down my throat. It's not a good look. You can't push etomidate too fast. If you do, the patient's jaw will lock. You'll end up giving them trismus, and then you won't be able to get in to intubate them. Okay, so you need to push it slowly. I see people just go, boom, etomidate, and you're like, oh no, we're definitely not going to get that airway now. Okay, so just make sure if you're, it happens, you get a little amped up, you're about to intubate somebody, make sure that etomidate is pushed slowly. You will know when the patient has been effectively etomidated. They kind of just go, and their whole jaw will go slack. Okay, and that's your cue. That's your cue to jump in there. Again, you'll see a lot more of that when you start doing your ALS rotations. Flumazenil, a drug you need to know, not in our protocol. It is the antidote for benzodiazepine. The state likes to use it, like to ask, what's the antidote? The antidotes. What's the antidote for benzodiazepine? Flumazenil. What's the antidote for Tylenol? N-acetylene. N-acetylene. Okay, those are the two antidotes they usually ask. We don't carry either of them, but you should be familiar with them. I've seen flumazenil given in the hospital a grand total of once for a patient who overdosed on her Ambien. She was a real grumpopotamus when she woke up. It's not pleasant. The problem with giving a patient flumazenil, one, benzos are relatively safe. Okay, most of the time patients they have them sleep it off. If you give flumazenil, you can cause them to go into having seizures, and then you can't control the seizures because you've now bumped the benzos off of their GABA receptors, and it's just a big hot mess. So you don't really see patients getting flumazenil all that often because it's just the cost-benefit ratio is just not there. Ketamine. Ketamine is growing in popularity, but you have some doctors, again, this is a medical control option only in the city. There are a lot of the doctors who are really nervous about using it. So you have to call and get permission. A lot of times it's going to be a mixed bag if you're going to have the opportunity to use it or not yet. Ketamine. Ew. Ketamine is a dissociative agent.
Oops, I'm sorry.
Okay. So you essentially will be putting this patient into Jupiter. Like they will have no concept of really what's going on. It does help raise blood pressure. The nice part about ketamine is it does not impact your respiratory drive. I know it says respiratory depression there, but for the most part, in the doses that we are giving, ketamine does not impact their respiratory drive. It will increase the blood pressure. So if you have a patient who's extremely hypertensive, who's maybe in a true excited delirium where their blood pressure is really high, it might not be the best for them. Okay, they might benefit from midazolam more than anything else. The problem also with ketamine is the patient comes back down off their high that you snowed them with. They might have some pretty wild hallucinations. Lorazepam, same thing as diazepam, works in the same way. This problem, though, the problem with lorazepam, why you don't see lorazepam / Ativan on ambulances is because it requires refrigeration. So it's just hard to store, so no one really carries it. You see it used a lot in the hospital. They'll stack lorazepam doses. They're like, all right, give him a milligram. That didn't work, give him another milligram. Oh, didn't work, give him another milligram. And they'll use small doses of lorazepam to kind of keep the patient chilling. Again, Midazolam, same mechanism of action, just basically the difference between the three include how you're administering it and how long they last. Midazolam is a longer onset. I've seen it work. It takes about 10 minutes, but it's a little bit of a shorter half-life. Whereas lorazepam usually lasts a little longer. Diazepam is I think is the one that lasts the longest. Midazolam does not require refrigeration like Ativan does. You will see midazolam on most NARC kits in the city. Even out in the counties, you'll see midazolam. Questions? All right. Pain management. Most popular one right now is fentanyl. Fentanyl, for the most part, all of your narcotics, fentanyl, morphine, they agonize the mu opioid receptors in the brain, which prevent pain from being transmitted into the brain. So you might be experiencing it, but that message of ow never gets to the head, okay? There currently, it sounds like the city is working to change their pain management protocol to kind of more closely mirror the protocols that we see out in Suffolk and Nassau, where if you're in pain as a medic, you can manage it. You know, you can just give the patient pain medication. Fentanyl, the standard dose is 1 milligram per kilogram. You sometimes want to maybe look at your patient if you just because you have a elderly lady who is 90 kilos doesn't necessarily mean you want to give her 90 kilos of fentanyl. You might really snow her, so just be cautious. Head injuries are a relative contraindication of all narcotics because sometimes it can cause a coma. Fentanyl is a lot more potent than morphine, and it usually creates less blood pressure impact. The one thing that's really kind of cool, not cool, but like from like you'll pick it up before like an anesthesiologist will. Fentanyl at very high doses, which is what they usually use if they're intubating somebody in like an OR, has the potential of causing chest wall rigidity. So I've seen this a couple times. Anesthesiologists will give the patient, like 100 milligrams of fentanyl and kind of slam it in, intubate the patient, and all of a sudden they feel like they can't ventilate the patient. It's because they've caused the whole chest wall to just, solidify, so they don't get good chest excursion. Make sure, again, this is a medication you want to give nice and easy. All morphine, like morphine and fentanyl, give it nice and easy. The problem with morphine that they do in the hospital is you'll see nurses will give morphine and then give promethazine right after, which is an antiemetic, because they'll slam morphine, which will cause nausea, and then they slam the promethazine, which is a nausea preventer. So it's like, oh, yep, I made you nauseous, but you didn't have to. If you pushed the morphine slow in the first place, you never would have had to give the patient more medication. Something to consider. Ketorolac. No, fentanyl's usually a little less respiratory depression, but again, it really depends on the patient. Some patients, yes, some patients, no. Depends on, body mass and a number of other things, but respiratory depression is usually a little bit less notable in fentanyl, or at least the fentanyl we're giving. Ketorolac or Toradol is very potent IV ibuprofen, essentially. Very, very useful in patients who have kidney stones. Most effective because it not only is a pain reliever, but it also helps reduce inflammation, which is what the kidney stone's kind of causing. Patients who are older than 64 really shouldn't be getting Toradol. It's a lot of risks associated with it in terms of kidney issues and GI bleeding. Again, if you're out in Nassau and Suffolk, this is in your protocol. If not, workout here. So we talked about lidocaine already. Just a quick reminder, you are only going to be using lidocaine in the city protocols as pain management for conscious IOs. Your initial dose is 1 milligram per kilogram. Sounds very familiar. Pops up a lot of lidocaine. then the next to a max of 100, I believe. And then your secondary dose is 0.5 milligram per kilogram. You want to make sure that you push it nice and slow, because if you slam that lidocaine into the IO, you're going to cause systemic response as opposed to that local anesthesia. Morphine. Morphine agonizes both the mu and the kappa opioid receptors, so it's a little more effective in musculoskeletal injuries than fentanyl. But again, if the patient's in pain, the patient's in pain. Most patients who get narcotics, there's a gender difference. Women generally don't experience as much pain relief as men do with morphine. So I do believe that this dose is still 5 milligrams of morphine with a repeat of 5. This can cross the blood placenta barrier, so patients who are pregnant, this might not be the best for them. Morphine will have a more depressed respiratory drive. Just remember that if you're giving the patient anything for pain, like any narcotics for pain, you always have the option of giving them a little bit of Narcan to reduce it if they start breathing too poorly. Questions, thoughts, concerns? All right. On Dancitron, aka Zofran. You will probably use this a lot in your career. Depends on how good you are with like the noise. Also, I am fully of the opinion that if you have a patient who's got severe nausea and vomiting, why not treat it? You have something relatively safe that can help make them feel loads better. And I think we're all we've all experienced terrible nausea vomiting before. And if someone had been like, hey, do you want me to take care of that? We all would have been like, yes, please. So your body experiences nausea and vomiting because of a serotonin influx in your brain. Okay, there's a specific part of in the medulla that causes vomiting. Basically, a lot of the times it's your body going, that is poisonous, toxic, we don't want it, get it out. So it causes an influx of serotonin in that part of the brain, and we all know how that ends. So what Zofran does is it comes and it blocks that the 5-HT3 receptor. Not something you're going to need to know, just edification, and helps reduce. You're going to give 4. It's weight-based, like 0.1 milligram per kilogram to a max of 4 with a potential redose. So just keep that in mind. You need to do cardiac monitoring on this patient because it has a potential side effect of prolonging the QT interval, which again, we'll go into cardiology. But just know that if you have a patient with prolonged QT and you give them Zofran, you're increasing the risk of putting them into torsade de poids. But again, Zofran, super helpful. Questions? Amyl nitrite, never seen it on an ambulance. In New York State exam, they love it for some reason. I don't know why. I feel like they recycle questions that you've never, or medications that we never see. Used in cyanide poisoning. If I remember correctly, you actually have the patient inhale it. We're not going to spend too much time on it. Hydroxycobalamin, though, we are going to spend some time on. Hydroxycobalamin is super cool, super effective, great in patients with cyanide poisoning and smoke inhalation. Okay, those are your 2 protocols that you're going to use it. If you're using it in cyanide poisoning, you actually need to have a class order for it because they're assuming that the cyanide poisoning is due to a terrorist attack. So for the most part, you're going to use it in smoke inhalation. Hydroxycobalamin is one of the B vitamins. When you give it to the patient via IV, it binds to cyanide and creates cyanocobalamin, which is very easily excreted by the kidneys. The patient's going to have this wild red urine afterwards, but it works really well. Basically, it just removes the cyanide from the cells and from the blood and allows the mitochondria to keep utilizing oxygen. cyanide poisoning is absolutely wild because you will be ventilating great, you'll have good perfusion, but you'll be like suffocating from the inside out because now your body just can't use oxygen because it turns off your mitochondria. So hydroxycobalamin comes in, pulls the cyanide out, and your mitochondria get to use oxygen again. Really
There's
cool.
no internal respiration, right? That's what it does.
Yes, exactly. It's refusing it the oxygen might be able to get into the cell. The process of that is that the process of getting into the cell, but it's not being able to be used by the cell. So the actual respiration or internal aerobic respiration is not occurring. Exactly. Narcan. Do I need to go over Narcan? I think we're pretty good with Narcan. I like to be very judicious when I administer Narcan because I work in a 5x8 box and I don't need a really crazy angry person in there with me. It bumps the opioids off the mu opioid receptors, reverses respiratory depression. That is what you're using Narcan for. You're not doing it because you have a sleepy patient who's breathing adequately. You're using Narcan because you have a patient who is not breathing effectively. You need to also be careful that you don't cause the patient to go into flash pulmonary edema. If you push too much Narcan too fast, their lungs will just fill up with fluid. It's this weird, quirky side effect of Narcan, okay? Taught CPR today, taught a little bit about Narcan. Narcan is relatively safe to administer, as long as you're administering it like not too much and not too fast. If you have a patient who has pinpoint pupils because of a brain bleed, but you're ruling out a narcotic overdose, Narcan's not going to hurt them. Okay, it's relatively safe. If you have a patient who's got severe respiratory depression due to alcohol and you give them Narcan because you're like, I don't know, maybe they had some narcotics with that alcohol, Narcan is not going to hurt them. Okay, so what's going to hurt them is you slamming 2 milligrams IV and then causing them to go into flash pulmonary edema. Okay, so vomiting also, if you're going to give a patient Narcan, don't stand right in front of them because you might wear some vomit. Pralidoxime, which is also 2-PAM. Okay, you see this in your weapons of mass destruction kit on the ambulance. No, it's not 2-PAM. Now I've confused myself. Pralidoxime. Maybe it is. Yes. Anyway, they use this for your weapons of mass destruction. Yes, it is 2-PAM. Sorry, I'm having a day. The number one thing that you need to remember that if you are opening up your weapons of mass destruction kit, those auto injectors, you put one in your pocket for yourself before you treat anybody else. Period. End of story. Because you cannot help anybody if you are also a victim of an organophosphate event, a weapons of mass destruction event. Okay. Basically, what it does is when you have, and we're going to talk about this, obviously, the whole action of how organophosphate poisoning and stuff like that happens, but it causes acetylcholine at the synapse to constantly stimulate the nerve. It breaks down the enzyme that removes it. So what 2-PAM does is it reactivates the enzyme that helps remove acetylcholine off of the neurojunction and resume normal neuromuscular function. Okay. I know that sounds like a lot. We're going to talk about it more in the future when we get to those things. And I think we've already covered it a little bit in weapons of mass destruction, but we'll probably end up reviewing it again. Sodium nitrite, again, never seen this on an ambulance. They like to know a little bit about it. It's good for cyanide poisoning, vasodilator. Don't worry about it too much. Sodium thiosulfate, however, is in your smoke inhalation. This is in your cyano kit box. When you guys start doing your rotations, I can tell you for sure on the Jamaica ALS ambulances, there's a cyano kit box. It's like about this big. It's white, says in red letters, cyanokit. Open it up and look at it, okay? You have to put your sodium thiosulfate and your hydroxycobalamin in separate IVs, okay? Do not run them in the same IV, big disaster. It also helps bind the cyanide ions and then excreted through urine. So your patient's going to be getting rid of a lot of cyanide through their urine. We are going to kind of gloss over this right now because in the city, none of these medications are being used. We're going to talk about, we've talked about these a little bit and how they work. They kind of work very similarly to organophosphates, where you're going to either agonize or antagonize the receptors or prevent the breakdown of acetylcholine. Okay, so basically what happens, depending on if it's a polarizing or depolarizing, which that is more important for you to know, that acetylcholine is a depolarizing, I can't say it. Vecuronium and rocuronium are non-depolarizing. That's probably the biggest takeaway you should have from this. They bind, they cause paralysis. You're able to intubate relatively easily. It's a paralytic, okay? Etomidate is not a paralytic. It's a sedative hypnotic. That's what we have in the city. We have what's called medication facilitated intubation, as opposed to acetylcholine, rocuronium, which are the two most popular, which are rapid sequence intubation. Regardless of what medications you're using, your most important thing is that you need to make sure that you have properly set yourself up for success. You've positioned the patient, you're oxygenating, you've got all your equipment set up, you are able to do, you've evaluated the airway and you're ready to go before you start paralyzing people. Okay, so just that's more important to me and to the patient than, understanding potentially the exact mechanisms of acetylcholine. Okay. I'm not sure if this is going to pop up on the test. I don't believe so. The more likely, you should probably understand that acetylcholine is a depolarizing muscle relaxant / paralytic, and it will cause muscle fasciculations, which is the shaking. Rocuronium will not. Rocuronium lasts longer than acetylcholine. Acetylcholine is relatively short lasting, 30-second onset, 3 to 5 minutes. Rocuronium can last about 15 to 30 minutes. It lasts a lot longer. The way that they work is slightly different, and that's why rocuronium is non-depolarizing. There's no fasciculations, no shaking. You should always, again, if you happen to be working in Suffolk and you happen to be using one of these paralytics, you need to pair it with a sedation, okay? Preferably a benzo, because that will also cause the patient to have amnesia, which means that they will not remember that you've paralyzed them and then stuffed a tube down their throat. Not something I would want to remember. Vecuronium is very, no. Vecuronium is very similar to rocuronium. It's a lot longer. It's the longest acting. So again, you're sedating, no muscle fasciculations because it's a non-depolarizing neuromuscular blocker. That's all I got for you guys. Yes, Rock and Vec are both longer. Sorry, let me breathe. Rock and Vec are a little longer on the onset, but they have a longer duration. So acetylcholine, you can kind of manage it if you were to. It's going to start a lot faster. That you're going to be paralyzing the patient, but they're going to start coming around a little bit faster. So you need to make sure they're adequately sedated. I see a question about Zofran. Hold on. PO Zofran, I believe is the same dose. I'm actually not sure. I don't see PO Zofran floating around all that often. I know there are some agencies that use it. And I believe that it comes in tablets that are just are sublingual and they just dissolve.
We have ODT Zofran and it's 2 milligrams.
Okay. Yeah, not super familiar with it. I know it works pretty well, but I think the ODT Zofran, the problem with that is people just steal it for when they're hungover. It's probably the more common use of the ODT Zofran. Because frankly, if you're vomiting and you're nauseous and vomiting, do you really want to put something in your mouth? No, give it to me IV. All right. Any other questions, guys?
I think Steve put one more in the chat if you want.
Yeah, I'm looking. I saw Steve said something about the fentanyl. Yeah, we covered the fentanyl, respiratory depression, fentanyl versus morphine. We covered that. Can you give 2 paralytics together? No, yeah, no. So, and this is a critical care thing. So if you have a patient and you've paralyzed them, you won't really see this in the 911 RSI setting, like the current like medic level standing. Yes, you absolutely can. I don't believe they like you switching back and forth between paralytics, but you have the option, I believe. Basically, what you're going to do is you're going to paralyze the patient, tube them, and then keep them sedated. If you're putting the patient on something like a ventilator, you want to continue the paralysis because it just makes it easier to ventilate them when they're not trying to breathe on their own. If you are manually ventilating them, you can kind of work around them a little bit better than a machine can. But there's nothing that I'm aware of that says that you can't do it. Actually, my medical director's next door. Let me go ask. Hold on one sec. There is an emphatic no, you can mix and match. No contraindication as per my medical director. You can mix those. But yeah, but again, it depends on your
one or the other. I mean, they don't like interact with each other.
They don't interact with each other in a negative way.
One's non-depolarizing, so some work like sucks. Then
what about for like length of transport? So like if you're
we always do that.
So
I always give them sucks to intubate them, and then if I need them,
maintain them on
rock.
rock.
Give them back a rock. That's totally normal. That's
awesome. Thank you. Yep. Did you all hear that? You're part of that. There you go. There's your answer directly from a doctor. Use your resources. Always use your resources, especially when you guys go to ICU. I'm going to say ICU is probably one of the more low key in terms of things that you're going to be able to do. Pick the doctor's brains. Ask these questions. These are fantastic questions. You're going to learn a lot. Ask them stuff about like, hey, like at what point are you going to say, hey, I want to intubate this patient versus, hey, I'm going to put them on a CPAP, because you're going to learn a lot more in that setting, because again, and that gives you, like we talked about before, those long-term effects of your patient care. So if you say, all right, I see this patient was brought in by ambulance. What did they do? Okay, so they intubated, they did this, they did that. Okay, what should they have done? What would have made this patient's prognosis better? What would have made their hospital stay better? Or did they do the right thing? So that's probably what you're going to get the most out of your ICU rotations for. Your ED, you're going to be doing a lot of IVs. You're going to be, again, ask us questions. When you have people who are around and you have easy access to, 110%, just ask as many questions as you can. Any other questions? That's a great question you had.
Nicole,
Mhm.
with regards to adenosine,
Mhm.
I was just looking at the protocol. It's still 6, 12, and 12 on standing order for rematch.
Okay.
And
yeah, they might be changing that in the future. Because I know the collabs.
and atropine is a max of 3 milligrams.
There you go. So awesome. Any other questions, thoughts, or concerns, guys?
Nicole, you ever heard of diphenhydramine being used with epi to better allow it to work with the beta agonists?
For anaphylaxis, yes, you can. If you look at your anaphylaxis protocol, you can give the patient the priority for anaphylaxis protocol when they're actually angioedema, epi 1 to 1000. Start an IV with fluids. Give them Benadryl, give them Solumedrol or Decadron, and if they're wheezing, give them albuterol. It's literally the one protocol that you will do absolutely everything that the hospital would do before you even get to the hospital. You'll get there and look like a rock star. But yes, they can be paired. But mostly when it's just in the anaphylaxis. An allergic reaction, you're just going to kind of just stick to the Benadryl, maybe the Solumedrol. You don't have to give epi. Anybody else?
Nicole, just as far as YouTube, none of the videos have posted recently.
Okay, I'll check it again. I know I tried using the WebEx to record, so it rather than my other thing that I was using, so it might not have processed right. I'll double check.
It's on
Okay.
Google Classroom. If
Yeah,
you go to the Google Classrooms and you go to recordings, you can click it, and that'll bring you to the YouTube link.
Does that bring you? Did it bring you to the last lecture?
Yeah.
What
Okay.
posted was lecture 6 a month ago.
Yeah,
All
but on Google Classroom, lecture 7 is there, the last one.
I might have set it to private by accident. Hold on. I'll check right now. Worry. You have lecture 6, so let me just see what my oh yeah, no, 7 apparently it's uploaded. Got 15 views. Yeah, I said it's you have to go through the link. That's why. I'll change this. I'll change the privacy setting on it.
Thank you.
You're welcome. All right, that should be good. This one will be uploaded as well as soon as it comes to me from the Magic Cloud. So hopefully it'll be up by tomorrow. Everybody's in the group chat right now, right? Where I can say, hey, if you guys want to do a review, we're going to do a review. And we can schedule it through there.
Yes.
Okay. So in that case, I'll see y'all.
To the next time.
To the next time.
Dragon Ball Z.
Yeah, so we'll set up a review. Please, 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 if you have questions, let me know. If we can do a review with a bunch of questions, and I'll even make a slide presentation for it so you guys have pictures, because my annotator on this guy clearly doesn't work that well. I'll put it in a Zoom instead, because Zoom's annotations drawings are way better than WebEx. So if you have questions, please let me know. We'll schedule a review. I want you guys to be super prepared for this test. I will look at it and I will give you a little more specifics. Okay? Please study. I know you guys had to do that survey. Questions that I would have asked on that survey as well for a little more addition. If you're asking questions, am I answering those questions adequately? Do you feel like you understand your question better? Okay. If you don't, please let me know and I'll try to come up with another way to explain it. You don't feel obligated to be like, hey, like, can you explain sucks? And I explain it and you're like, I'm still confused. Please let me know that, because then I will try to come up with I'll draw a picture. I'll come up with some random hand motions or whatever it is, interpretive dance. But let me know if you don't feel confident that I have explained it. Please let me know. Any other concerns, please, 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 just throw it in the chat, send me a message, send me an email. Let's get you all to a point where you're feeling really confident in your knowledge. Okay?
Yes.
One more question.
Go ahead.
Can you explain what we're supposed to do with homework one more time? I'm reading, trying to figure out what I have to do here.
To deal with what, homework?
Yeah, what you wanted us to do today with the the GOP special meds?
Oh yeah, so
Let's go with
I
that.
want you to go into your protocols. I want you to find there's like 3 or 4 medications that have special considerations. Okay, so it's like it's either you do give it to this if you have a patient who has a certain medical problem, you're going to reduce the dose. Those it's like 3 or 4 of them. Go into your protocols, find them, write me an email with what that special consideration is. That's it. I just
Okay, thank you.
give me evidence that you have gone to your protocols and looked at them. Pretty much it. I think I've got everybody's homework. I'll let you know if I haven't gotten it. Other than that, have a great day, guys. Thank you for being
Well,
so
also,
accommodating. Yeah, go ahead.
real quick, just so everybody can check their survey that they did. I noticed it the other day. I didn't think about it. It says the survey was for exam 5A. We didn't take 5A yet.
No, that was just a general, like, he put the survey under exams, so he made it exam 5A. It's not actually
Okay.
based off of an exam.
All right. Cool.
All right, guys. Have a great day. I will see you on the flip side. We'll schedule a review.
Thanks, Nicole.
Thanks, Nicole.
Thank you,
Bye,
Nicole.
guys.
All right, guys.
Bye.
Bye.